Hello, and welcome to session 2B, How Lifestyle Behaviors Shape Health. I'm Sherry Shelley, and I'm the Deputy Chief Medical and Scientific Officer of the All of Us Research Program. Before we get started, I wanted to share some housekeeping notes. Closed captions are available. Click the CC icon in the top right to enable them and to select your preferred language. If you experience technical issues or need accommodations, please email allofuscienceday@pyxispartners.co. To ask a question, use the Q&A feature in the top right of your screen. The Q&A is private and monitored by All of Us staff. The chat is public and will not be monitored for questions, so please be mindful of any personal information that you share. I'm delighted today to introduce our panelists, so please join me in welcoming Dr. Neil Zhang and Dr. Malish Shainos. Dr. Zhang's research explores how wearable technologies and behavioral lifestyle changes can be harnessed through biomedical informatics to better understand and prevent chronic cardiovascular disease. Dr. Shainos will be describing ongoing collaborations with Google Health IT at Vanderbilt that aims to enhance cardiovascular risk prediction using Fitbit-derived behavioral data. During the presentations, if you have any questions, remember to put them in the Q&A panel, and we will get to them during the Q&A portion at the end of this session. Today, we will be beginning with Dr. Zhang. So welcome, Dr. Zhang.
Thank you for having me, and thank you for the introduction. I'm excited to be here today to share the research that we've been working on over the past couple of years, namely looking at daily steps and physical activities such as sedentary behavior in the All of Us research program. So this is a brief summary slide of what I'll cover today. What we did is we focused on the interaction between daily steps and sedentary behavior with relation to 12 different chronic diseases, including cardiometabolic disease, as well as other non-cardiometabolic disease, such as kidney disease, some lung disease, as well as depression. What we found was that increasing daily steps can, broadly speaking, offset risk of sedentary behavior for many of these chronic conditions, with a couple notable exceptions. And our hope is that our results will enable guidelines from national societies on how to tailor behavioral patterns such as daily steps and sedentary behavior to the individual, and really empower patients and their healthcare providers to take advantage of all the different kind of data that we have nowadays for physical activity. Of course, this research is made possible by the All of Us research program, which we are very thankful for all of the generosity of our participants, as well as the dedication of all the researchers, including those before me. So what is sedentary behavior? Broadly speaking, sedentary behavior is any waking behavior with low energy expenditure. And so by the official definitions, low energy expenditures, they look at metabolic equivalents. But if we just use a general definition, it can be described as sitting, lounging, lying down. So imagine sitting at your desk doing work, driving, eating dinner at table, or even watching television. These would all be considered sedentary behaviors. And it's very common. This is a great figure from the 2025 JAMA paper, which looked at sedentary behavior trends in the US over the last decade or so. And so we actually look in 2013 and 2014, the percentage of individuals or adults in the United States who had sedentary behavior was about 50%. And this has come down over the last 10 years. Now it's about 1 in 3 adults, which is still fairly high. And globally, it's around the same percentage. So globally, the prevalence of sedentary behavior or prolonged sedentary behavior is about 1 in 3 adults. And many studies, including ours, have shown that prolonged sedentary behavior raises risk for all-cause mortality as well as chronic diseases. In our study, this is a figure from our study, we looked at these 12 different conditions, and risk for these chronic conditions generally increases around 12 hours of daily sedentary time. And these plots are plots of hazard ratios, which we can broadly say is risk over the x-axis here, which is sedentary hours. And so as you see, as you increase sedentary hours, you increase risk for most of these conditions. This is a comparison to the population median, which is about 11 hours of sedentary time. So our research question becomes, we know that prolonged sedentary behavior is unhealthy, and many studies have shown this. However, it's quite difficult to decrease sedentary behavior. If you imagine your occupation, you drive for a living, or you sit at a desk for a living, and you work at a desk, it can be hard to reduce the amount of sedentary time you have just because you're locked in for that period of time. So then our question becomes, can we take extra steps outside of those periods of sedentary behavior that will offset that risk? So say you go home after work, can you take a 20-minute walk, and would that offset the extra time that you spent sitting down? In our study, we looked at about 15,000 adult participants in the All of Us study, which have Fitbit device data, and we linked them to health outcome data from electronic health records. This includes over 13 million days of observation with a median monitoring period of almost 4 years. This is the largest data set of physical activity across all the different studies that are available. So this was a very exciting data set we were really excited to use. We entered these variables as time-varying variables. So we looked at monthly sedentary time and monthly daily steps, and we entered them into survival curves and survival analyses and Cox proportional hazard models. We looked at the 12 selected chronic diseases that I showed earlier, including cardiometabolic diseases such as obesity, coronary artery disease, heart failure, as well as some non-cardiometabolic diseases such as kidney disease, MASLD, metabolic associated liver steatotic disease, as well as chronic obstructive pulmonary disease. A lot of long names. So for these 12 different conditions, we see that increased steps can offset risk of sedentary behavior for most of these conditions. And protection generally begins around 6,000 to 8,000 steps. And so in these plots, what we did is we have 4 different curves, one for each category of sedentary time. So individuals with 14 hours of sedentary time is the yellow curve. Those with 8 hours is the purple curve. And generally speaking, those who have more sedentary time require more steps. The steps is our x-axis here. But it is important to note that the number of daily steps needed varies by the condition. On the left here, we have hypertension. And you can see that most of these sedentary time curves, they're kind of tracking fairly similarly. And the difference between those with 14 hours and the difference between those with 14 hours and 8 hours is about 2,000 steps. And so those who have 14 hours of daily sedentary time need additional 2,000 steps compared to those with 8 hours to offset that risk of hypertension. On the right side, we see diabetes, and here the curves diverge. And so those with 14 hours of sedentary time need additional 5,000 steps approximately to offset that risk of diabetes compared to those with 8 hours. It is important to note that daily steps cannot offset the risk of sedentary behavior for all conditions, most notably for coronary artery disease and heart failure. You can see that the yellow curve here never crosses that dotted line around 1. So that means that those with 14 hours of sedentary time, no number of additional steps will offset your risk of sedentary behavior compared to those with 8 hours. And so you're always going to be at higher risk of coronary artery disease. There are a couple limitations to this study. One, our physical activity data was derived from Fitbit devices, and Fitbit devices are fairly accurate and they have been validated against gold standard actigraphy, but there's still potential for misclassification there. Our study cohort is relatively young, majority female, white, and college educated. This is a voluntary shared data set, so tends to be on the younger side. That means that there may be some limits to the generalization to the overall population, but to note, the population is also pretty young and healthy, and so there was some limits to the amount of samples that we could do for all conditions. We did choose 12 conditions that we felt were sufficiently powered to be able to do our analyses. For any sort of chronic disease analysis, it's important to consider family history, dietary habits, and medication history. They are not included in our current analysis, but would be interesting to look at in future studies. So what are our takeaways? We have 3, I think, big ones. 1, prolonged sedentary behavior is broadly associated with increased risk. And so that means that if you have prolonged sedentary behavior, one of the best things you can do is just to reduce that. And that's true for pretty much all the conditions that we saw. However, for those who are unable to reduce their prolonged sedentary behavior, daily steps can offset the risk for many of these conditions. Again, the notable exceptions are coronary artery disease and heart failure, which are fairly important severe cardiovascular disease. So it is important to reduce or prolong sedentary behavior and also take more steps. Our hope is that the data from our study, including the quantitative data, will eventually make their way into national guidelines in terms of how to recommend daily steps and sedentary behavior to the individual. And so, with nowadays, with wearable devices becoming more popular, or even smartphones that are tracking step count, our hope is that patients and their healthcare providers can really come together and make a plan tailored to the individual based on their behavioral patterns as well as their chronic disease risk. I want to thank the NIH, the All of Us program for making all this data available, and of course my mentors over at Vanderbilt University Medical Center, especially Dr. Evan Brin, who was my mentor over the past couple of years. Thank you.
Thank you so much, Dr. Zhang, for that exciting presentation. Now I'd like to bring Dr. Shynose to the stage, to the virtual stage, and have her give us her take on similar data. Over to you.
Thank you for having me, and thank you for the introduction. So today I'll be talking about our research study from risk to risk, advancing cardiovascular prediction using wearable devices. And this is a brief overview of my slides, and this is a brief research summary. So basically, we conducted a retrospective cohort study using the data from All of Us research program to assess whether wearable-derived metrics related to physical activity, sleep, and heart rate could improve prediction of incident atherosclerotic cardiovascular disease beyond established risk scores in adults without pre-existing cardiovascular disease, so in the primary prevention realm. I will talk extensively about our results, but briefly, daily step count and resting heart rate were the prevailing Fitbit variables that improved cardiovascular risk prediction in our study. And we think that the study is important because wearable-derived metrics such as daily step count and resting heart rate offer a scalable and accessible way to enhance traditional cardiovascular risk assessment, particularly in risk stratification in the lower risk population. So quick background, we all know that early identification of individuals at high risk for cardiovascular events such as myocardial infarction, heart failure, and stroke may facilitate timely prevention efforts. Traditional cardiovascular risk scores, such as the Prevent Risk Score, which is what you're seeing on my screen here, are widely used to estimate cardiovascular risk. However, other than tobacco use, they don't incorporate any behavioral lifestyle factors such as physical activity or sleep patterns, and these are strongly linked to cardiovascular health. Wearable devices provide continuous real-time behavioral data, which may enhance cardiovascular risk prediction models. And in this study, we hypothesized that real-time behavioral data through Fitbit devices will improve performance of cardiovascular risk prediction compared with conventional models that use only clinical and demographic data. So here are our methods. We performed an observational retrospective cohort study using the electronic health record-derived clinical data in the All of Us dataset, linked to wearable data through Fitbit devices in collaboration with Google. We included all participants over the age of 18 with linked wearable and electronic health data and excluded individuals with known cardiovascular disease. Our main outcome was incident atherosclerotic cardiovascular disease, which was defined by ICD-10 codes for coronary artery disease, acute coronary syndrome, ischemic stroke, peripheral artery disease, and CPT codes for percutaneous coronary intervention, coronary artery bypass grafting. We assessed the ASCVD risk using the PREVENT equations. Here are the baseline characteristics of our cohort. We had a total of 4,216 participants. The median age was 54, and the population was predominantly white, with mostly identifying as female. Median BMI was 28, and about 10% had diabetes, 61% were on antihypertensive therapy, and about 36% were on statins. The median PREVENT estimated 10-year ASCVD risk was 2.9%, consistent with a predominantly low to borderline risk population. Our median duration of follow-up with longitudinal Fitbit data was 5.3 years, and during this follow-up period, a total of 223 individuals developed incident ASCVD. The median average daily step count was about 7,000 steps per day, and the median average resting heart rate was 61 beats per minute. Participants slept a median of 6.6 hours per night with moderate variability in sleep duration, reflected by a standard deviation of about 78 minutes in nightly sleep duration. We then developed sequential models to assess the incremental contribution of wearable metrics beyond the PREVENT risk score. So here you see the base model that included PREVENT risk score alone, which had a C statistic of 0.7 in our cohort. This is slightly lower than the reported C statistic of 0.74 on the PREVENT publication. We then added Fitbit variables to this baseline model and found that step count and resting heart rate independently were the Fitbit measures that contribute to the model performance significantly. We confirmed these findings using the likelihood ratio test, which is considered the gold standard test for comparing nested models to determine which model performs better. In contrast, when other Fitbit measures, such as the MVPA, which is a Fitbit metric for moderate vigorous physical activity, which is a total duration of physical activity corresponding to 3 or higher minutes of sleep per night, or standard deviations of minutes of sleep per night, which corresponds to consistency of sleep duration. When these were added to the base model, they did not improve the predictive performance of the model significantly. So overall, we found that step count and resting heart rate were the prevailing Fitbit measures that improve model performance when added to PREVENT risk score. These graphs are showing how these Fitbit variables perform compared to the other risk factors in these two models that we had in the prior slide that go into PREVENT. And so these are the two models that outperform the PREVENT-only model in our cohort in the previous slide that I presented. So the one on the left has resting heart rate in addition to other variables, and the one on the right has step count in addition to the other PREVENT variables. And as you see in both models, age and sex seems to be the strongest variables that predict incident ASCVD, followed by resting heart rate on the left panel and mean daily step count on the right panel. So when added to the PREVENT risk score calculation, steps and resting heart rate are important contributors to these models and outperform the other model components other than age and sex. Now here we try to assess the diagnostic accuracy of using only Fitbit variables to discriminate across different risk group categories according to PREVENT. So this is a different analysis that compared to the last two slides that I shared. So here, the Fitbit-only model demonstrated strong discriminatory ability in distinguishing low versus borderline risk, and especially low versus intermediate ASCVD risk groups. And these are risk groups per the PREVENT equation. So when subject known variables such as age, sex, statin use, antihypertensive use, diabetes status, and smoke status were added, again, without needing any lab values, as we recognize that not everybody would always have access to a clinical care and lab values, model performance improved overall. So in summary, these findings suggest that Fitbit-derived metrics, along with some basic patient-known demographic and clinical information, can meaningfully estimate clinical risk in categories in the absence of measured lab values. So this could be used to alert patients to seek medical care when their estimated risk is rising and potentially reach above 5%, which is, per the new dyslipidemia guidelines, significant. And that should warrant therapy or at least discussion with a clinician. So in our cohort, step count and resting heart rate were the most informative Fitbit-derived variables, enhancing the predictive accuracy of the PREVENT risk score. Fitbit-derived metrics combined with basic patient-reported demographic and clinical information can accurately predict clinical ASCVD risk categories in the absence of laboratory data. Our study has lots of limitations. Key limitations include potential selection bias from a relatively healthy study population, as well as unmeasured health disparities. Obviously, not everybody has access to wearable devices, and inherent constraints of EHR-based observational data. Our results require validation in external and more diverse cohorts. This is our research team. Thank you everyone for their participation, especially my mentor, Dr. Evan Britton, and all the folks at Google. And thank you to all of us research program for making this research study possible.
Thank you so much, Dr. Shinos. I'd like to invite Dr. Zhang back to our virtual stage. We have a lot of time for question and answers during this session, so please make sure that you're going to the Q&A tab to actually publish any questions that you may have. And I'm going to start off with one from the audience. And so to both you, but I think it was aimed towards Dr. Zhang. Are there other activities such as short bursts of high impact training that might offset sedentary behavior?
Yeah, I think this is a great question. As you probably alluded to, a lot of the current national guidelines around physical activity are based on moderate to vigorous activity. And so they recommend 150 minutes per week. So that's about 30 minutes for 5 days a week. There was a paper that was published last year using UK Biobank data. And what they did is they looked at physical activity over the course of about 1 to 2 weeks and looked at what the outcomes would look like or what the risk would look like if you substituted sedentary behavior for moderate to vigorous activity. And they do show that as you substitute sedentary behavior for more moderate to vigorous activity, your risk of cardiovascular disease decreases. And so there is a lot of value in not just steps, but if you are, for example, on a bike or swimming, these are all great activities to substitute.
Dr. Shinos, anything to add?
No, I agree. I think that was a great explanation.
Great. I have another question. Subsequent to giving samples to all of us, I learned that I have a high lipoprotein A. My father died of an MI at age 56. I'm now 74 with a negative cardiac calcium test. Are you looking at lipoprotein A, and are there plans to take more samples? So I'll actually take this as the Deputy Chief Medical and Scientific Officer of the program. We do not have plans to take more samples for lipoprotein A. However, is in Dr. Denny's opening remarks, he actually mentioned how we're diving deeper into the electronic health record. And in those cases, we'll be able to actually pull test results from the electronic health record that can then be added to things like physical activity and other things that the speakers today walk through and help us get a better idea of sort of how test values like lipoprotein A may actually be informing the other things that are sort of going on in your life, whether that be smoking, diet, or physical activity. So hopefully that answers your question. Otherwise, we don't plan on collecting more samples specifically for that risk. There was a comment in the public chat that ask if the program plans to collect the Apple Watch data, or does it have to be Fitbit? So we are working to incorporate Apple Health Kit into our data that's going to be available, and that will actually be available in version 9 of our data. And so as Dr. Denny mentioned in the beginning opening session, we hope that that will be released late spring, early summer. And so people will be able to do things like compare Apple Health Kit data to Fitbit data and, start to answer some more methodological questions about, which is performing better and which, you might want to be working, using or and things like that. So the exciting thing is it's coming. It's not here yet. So we're not able to actually present on it yet. But very soon, hopefully at the next Science Day, you'll see some presentations that actually talk about Apple Health Kit and how we're able to tie that into some of the data we're seeing here today. Okay, we've got another question. Could you please comment on how your team examined completeness, missing records, and the validity of the EHR when you were doing your analyses?
Yeah, I can take that one. I was actually typing the response on chat. So that's a great question. So we had multiple parameters to assess the completeness of Fitbit data, and that's such as number of steps below. I can't remember the exact numbers now, but number of steps below like 1,000 per day, or less than 500 per day, or above 45,000 per day. So that's to kind of, or sleep duration less than 1 hour per day. So that's to kind of assess the completeness, and that was part of our exclusion criteria. So we had very rigorous exclusion criteria, and then for the rest of the study in general, we used multiple imputation, which is a statistical method to avoid bias when we exclude all the people without incomplete data. So we use multiple statistical techniques to ensure we included significantly sufficient data, both for Fitbit and for lab values and other demographic values.
Yeah, I'll just add it's pretty similar methodology in the terms of the way we cleaned the Fitbit data and the way we looked at the outcomes. There's always a limitation with electronic health record data in terms of outcomes where people may be misdiagnosed or underdiagnosed. We just have to hope that individuals come to the doctor frequently enough where they're getting these diagnoses. But when you're looking at sort of large scale data, the idea there is that you're going to have enough people, enough sample size to actually be able to not worry about the noise so much. I do think that diagnosis codes is what we use for the electronic health records, and they've been used in a lot of different studies and have generally been pretty reliable.
Great. Were the Fitbit variables averaged over time for each individual? Were the Fitbit data collected before or after disease onset in these cases?
Yeah, I can go first. We did average Fitbit data, and we collected the Fitbit data before. For the 223 people who developed cardiovascular disease, we averaged the Fitbit data before the onset of disease. And so we used their data before developing cardiovascular disease to be able to predict cardiovascular disease.
Dr. Zhang, in your study?
Yeah, this is, again, a great question. So what we did was we took the monthly averages of physical activity and we entered them as time-varying variables. So we actually look at the trend over time for each month for the physical activity and the sedentary behavior. We have a 6-month blanking period in the sense that when you start Fitbit monitoring, you have 6 months where anybody who has an outcome within those 6 months, we exclude them from the study. And the reason why we do that is we try to avoid something called reverse causation, where you can imagine someone gets, for example, heart failure, and they're not able to walk as much, and they're more sedentary after they have heart failure. We want to avoid that kind of reverse causation there. So we have that 6-month period. So all these outcomes are going to be incident diagnoses after that 6-month period.
Thank you very much. I'm going to hit on another topic that we already hit on. Any hope of adding other wearable data such as Google Fit, et cetera? As I mentioned, Apple Health Kit is coming in our next iteration, and we would love to bring in every wearable data that we could. The issue sort of runs up against funding and whether or not we can pull that data in a meaningful way on all of our participants. So more to come on that, but right now it's Fitbit and Apple Health Kit. Okay. So someone's interested in the behavioral lifestyle impact of just consistently wearing a Fitbit versus not, as well as the associated factor of those who start and then stop using a watch. Do you know of any work that's going on in this behavior space?
I don't know off the top of my head. I mean, I think it's a really interesting question, and it's something that we're pretty aware of when we studied this cohort, because as you can imagine, those who are wearing wearable devices are probably a little bit more health conscious, probably are focusing on their physical activity more than the general population. And so that is one of the limitations of anything that is using the Fitbit data in the All of Us study, is that this is a very specific cohort. And as we saw, they're relatively young, relatively healthy. I do think that we see enough associations that are similar to those who are using survey data from the general population, where it's pretty consistent across all of these different kinds of studies that show similar results. So that's really reassuring, but it is something that is kind of interesting. There is an initiative from the All of Us data research program called the WEAR study, where they're actually providing Fitbit studies to historically underrepresented patient populations. And that's a great study, because you're giving these Fitbit devices tracking physical activity in individuals who might not typically wear one of these devices. But I don't know off the top of my head, or I'm not really aware of the literature around behavioral impacts around wearing a device.
I know that there has been a lot of data about people wearing the device while they sleep, and that varies quite greatly as well. So hopefully with the All of Us data set, we're able to answer a lot of those questions. I'm going to do my best to combine two questions that I think are completely linked. So the first one is, how do you characterize the overall reliability of Fitbit-related measures in your studies? And the second part that I'm adding in is anyone publishing sort of consensus algorithms for cleaning and summarizing Fitbit data and developing categories for what people should be using in analyses moving forward?
I can talk a little bit about kind of the algorithms. I will say that the Fitbit devices, most of the validation have been done in prior studies that are not related to at least my work. And they compare Fitbit devices to Apple Watches, to gold standard actigraphy, which are like wrist-based movement devices. And generally speaking, they're pretty good. They also compare Fitbit sleep algorithms to the polysomnograms, which are the gold standard for sleep, and generally are pretty good. Like I said, there's probably some degree of misestimation, but our hope is that on a broad scale, that the noise as well as the misclassification won't impact the results too much. The consensus algorithms is another interesting question. At least the group at Vanderbilt, which I think both of us have worked with and for these two studies, has published their algorithm in previous papers. So I would point you to, there is a step count paper that was published, I believe, in 2023 in Nature Medicine, which has that algorithm published, and it looks at all the different cleaning steps for the step count and physical activity. My work currently is being published at Nature Communications, actually like last week. So you can take a look at the algorithm there as well. And then for sleep, there was a paper published also from the group, I think last year, that also looks at how to clean the sleep. And so these were the general recommendations that I would recommend you take a look at.
Louise, anything to add?
No, I agree. I think that was a very comprehensive answer. I also want to point out, I think there was another question, if it's okay to mention. I want to make sure that I'm able to answer in the chat about, I should have clarified what prevent calculations are, and so kind of also combining lipoprotein A question earlier as well. So prevent equations are risk calculation to estimate cardiovascular risk for individuals without known cardiovascular disease. And so they're now endorsed by the ACC, American Heart Association, American College of Cardiology. There's actually a risk calculator. So even for our patients, if you know some of your lab values, like your cholesterol values, your blood pressure, then you can search Prevent Risk Calculator online, and you can calculate your own risk. And we guide our statin therapy mainly by the Prevent Risk, and we reassess risk, and sometimes we obtain a calcium score. I think one of the members of the audience mentioned about calcium score. Lipoprotein A level is not on there, and we did not include lipoprotein A levels in our in our study. However, it is a risk enhancer, and so it is important while we're assessing somebody's overall comprehensive risk. Your calcium score may be 0 now, but if you have elevated cholesterol and elevated lipoprotein A levels over time, it still puts you at risk of developing plaque in the arteries and cardiovascular disease. I would also like to plug in and mention that we also developed, in collaboration with some other colleagues, a risk calculator tool, both for physicians and it could be used by patients, and you can discuss that with your clinician as well. Basically incorporating the newest dyslipidemia, so high cholesterol guidelines that came out in 2026. And you can search ascvd.org, and that should take you to the risk, basically the online tool. And that kind of shows for that, it has prevent calculations embedded in it as well. And it shows you not just what your risk is, but also per the most recent cholesterol guidelines, what would be recommended. Obviously, this should be discussed with your clinician, but I think it's a good starting point, especially if you're interested in kind of getting more information about your risk. And it's also our main goal was to kind of have that tool guide clinicians as well while they're thinking of how to tailor therapy. Sorry, I took a sidetrack, but
oh, that's fine. Thank you. We have another question, similar to one that you've heard before, but besides walking, have you seen whether yoga and or Pilates, who are more low impact, are also helpful in lowering risk of chronic and non-chronic diseases? And how many minutes of each would be helpful, especially for those in middle age and those who are in their golden years?
I think that's a wonderful question. I am not aware of any studies currently that have looked at that. I think one of the tricky things to study that is that if we're looking at physical activity from watch-based devices, they're mostly estimating your physical activity based on your heart rate and the movement. And so the low impact activities such as Pilates or yoga is a little bit harder to track. I think that would be really great for there to be some sort of maybe survey or even prospective study to look at that. But I think it'd be a little bit challenging to study in the All of Us data set.
But I think overall it's important to mention those activities are not just good for your cardiovascular health, but also using body weight. It's important to focus on body weight and like resistance training. And so even if you're using body weight with Pilates or yoga, it's not just good for your cardiovascular health, but for overall health, and especially musculoskeletal, especially in women. It's usually overlooked. But it's very, very important. So it should not be a barrier that we're not able to track and kind of publish studies on that, but it's very important.
The next question, I want to preface with the All of Us research program is exactly a research program, and so we don't give clinical advice. But if a participant or a patient had a Fitbit and their heart rate went down from 68 beats per minute to 60, and also had an active heart rate that decreased from 94 to 82, would you necessarily think that that might be an undiagnosed heart condition, or is that something they should talk to their doctor about?
Yeah, I could take that. So we know that overall lower resting heart rate is associated with better cardiovascular mortality, better cardiovascular risk. However, it should be taken in context. And so overall, the answer is that should be discussed with your clinician. If you're experiencing any symptoms, or if you start a new medication, certain medications reduce your heart rate, or if you started experiencing lightheadedness or passing out, then that could actually point to a cardiac pathology. So it should be taken in context of what has changed. So ultimately it should be discussed with your provider.
So I know that neither one of you touched on the sleep data from Fitbit, but with the data available in the All of Us researcher workbench, would it be possible to look at medication history along with the sleep data to see how medications affect sleep?
Yeah, this is a really interesting question. I actually did start a preliminary project looking particularly at medications' effects on sleep. It's a little bit tricky in the All of Us data set. The reason being is that you have prescription data for medications, but you don't have medication adherence and you don't have over-the-counter medications necessarily unless the patient reports it. So if you imagine like a medication like melatonin, which is probably one of the most common over-the-counter medications for sleep, a lot of people just buy it from their local CVS or Walgreens, and therefore they don't report that to their doctor that they're taking that. And so there's a lot of challenge in teasing out what is a true signal versus what is noise there. And I'll just say from the preliminary stuff that I've seen from my data, I can't find any sort of association with melatonin. But again, there's a lot of noise there, and I'm not sure what is real or what is not. And so I think it'll take a little bit of work to really look into that data. It's a really interesting question, though.
Have either of you tried cross-referencing this data that you've used with participants' metabolic data?
Personally, I have not. I think that is an area that would be really interesting to look at. I have not worked very closely with the lab data, All of Us, but it is available. And that is certainly an area that I think will be a great place for further research to be done.
And I'll make a quick plug here that we are actually collecting metabolomic data. So getting to the omics, similar to genomics, but on the how you metabolize things within certain participants within All of Us. So that will be possible in the next few years. Okay, here's an interesting question. I'm not going to get into the specifics, but if a participant happens to have a risk factor for cardiovascular disease, do you have an overall idea of how much activity, environmental factors, et cetera, can override genetics? So sort of the interplay of gene by environment interactions.
Yeah, so we're also working on a publication on this project that I just talked about, and we actually have we actually came up with a graph where comparing people with different risk categories. So at a certain risk, how many steps per day that you need to take to be at an equivalent risk to a reference individual. So stay tuned. There'll be more information coming out hopefully soon. But clinically speaking, I guess we focus on all the modifiable risk factors as we cannot change genetics. Age and sex, I mentioned, are the two most important predictors of cardiovascular disease. We can't change those. We can't change genetics. So really things coming after are, in addition to exercise and healthy diet, and Mediterranean diet, controlling blood pressure, which is a very important modifiable risk factor, controlling high lipids, so controlling cholesterol is very important, and if you have diabetes or prediabetes, controlling that. So we really focus on modifiable risk factors at that point. And there's usually a lot we can do on those modifiable risk factors, and same with weight loss.
Great. I see that we only have about a minute left, so I'm going to take moderator's prerogative to choose the last question. Do either of you have plans to incorporate some of the genomic data that is very rich within All of Us with the Fitbit data?
Yeah, that is a great question, and it would be a great study. We don't have any plans for that as of yet, but that's a great point. We should think more about that. I don't know if you have any plans.
Yeah, I think, like mentioned, stay tuned. I think there's some work looking at polygenic risk scores and genetic risk for different chronic diseases, and how one with a high genetic risk for a disease might be able to reduce their overall disease by taking more steps or sleeping better. So that work is in progress. It's definitely stay tuned.
Great. So first, I want to thank our speakers today for doing such a wonderful job, specifically talking about how we can start to incorporate our Fitbit data into sort of how we can shape our lifestyle behaviors to help shape our health, and for showing us how they use the All of Us data set. And thank you to all of you for joining us. Up next is a 30-minute break. During the break, please explore scientific session abstracts and posters. Cast your vote for the People's Choice Awards, and we'll return at 1 p.m. Eastern Time for Session 3, the Poster Lightning Talks. Thank you so much.